Hi, my name is Gavin Harris, and I'm here to discuss the management of the patient exposed to hantavirus. First, some disclosures. This presentation is made possible through a grant from the Administration for Strategic Preparedness and Response, or ASPR. The contents, importantly, do not represent the official policy of the United States government, and this information is not meant to be a substitute for professional medical advice, diagnosis, or treatment. I have no relevant conflicts of financial interest or relationships to disclose. Here is our agenda for this presentation. We will begin with a brief background on hantavirus. We'll discuss how to recognize the clinical presentation. We'll also discuss how to manage and treat it, and then ask the question, can it be prevented? So first, some background. Hantaviruses are members of the order Bunyaviridae, which includes families that cause viral hemorrhagic fevers. The family for hantaviruses is known as Hantaviridae. In the Americas, hantaviruses are known as New World hantaviruses and are the causative agents of hantavirus pulmonary syndrome, otherwise known as HPS. Hantaviruses found in Europe and Asia are known as Old World hantaviruses and can cause the syndrome hemorrhagic fever with renal syndrome, or HFRS. Hantaviruses are single-stranded RNA viruses, and there are over 20 known species in the world today. Hantaviruses can infect many species of rodents, including shrews, moles, and bats, without causing any visible disease. In the United States, the cotton rat, the deer mouse, the rice rat, and the white-footed mouse have all been identified as vectors. In the most well-known outbreak of Sin nombre virus in 1993 in the Four Corners, the deer mouse was identified as the primary vector. While the traditional mode of transmission for hantavirus is via the inhalation of droplets through aerosol exposure to rodential bodily fluids, with at least one species of hantavirus that is found in South America, Andes virus, airborne person-to-person spread has been documented. However, rodent infestation in and around homes and dwellings does remain the primary risk for hantavirus exposure. We'll continue with the discussion of hantavirus pulmonary syndrome, or HPS. This syndrome is defined by the following: a fever greater than 38.3 degrees Celsius or 101 degrees Fahrenheit, bilateral diffuse interstitial edema, respiratory compromise that requires supplemental oxygen that is often quite rapid and occurs within 72 hours of hospitalization, all of this occurring in a previously healthy person with a positive epidemiologic linkage to rodents or rodential fluids. Now, the clinical progression of HPS is often divided into three specific phases. This is the major form of hantaviral disease. It has been associated with Sin nombre virus and Andes virus, and the incubation period can often be quite long from exposure to rodential bodily fluids or rodents themselves. The incubation period can last from 9 to 40 days with a median of 14 to 17 days, which is about 1 to 8 weeks after exposure. The earliest clinical manifestations of HPS is part of what we call the prodromal phase and includes nonspecific symptoms like fever, chills, myalgias initially, in addition to the clinical case definition symptoms that we just mentioned, and the progression from this phase can often be quite rapid to include nausea, vomiting, diarrhea, acute abdominal pain, and other gastrointestinal symptoms. It's also important to note that Andes virus, HPS, can present with conjunctivitis, facial erythema, and petechiae, which makes it quite different from more common causes of HPS. Following this prodromal phase, there is often a rapid onset to ARDS, or acute respiratory distress syndrome, where capillary leak can occur and cardiac output falls. This brings us to the second phase, often the most deadly, the cardiopulmonary or cardiorespiratory phase. This phase can last from 2 to 7 days or even more, depending on how the patient progresses. It's characterized by hypotension or shock, non-cardiogenic pulmonary edema and ARDS. Again, that is often quite rapid. And its initial symptom may often be dry cough. It can progress with coagulopathy, leading to hemorrhage, and arrhythmias can often be quite rapid as well. As you can see on the screen, laboratory abnormalities often include a decrease in platelet count or thrombocytopenia, an elevation in hepatic enzymes, as well as lactate dehydrogenase. If the patient survives the cardiorespiratory or cardiopulmonary phase, they will progress into the convalescent phase. This phase can be extremely rapid as well. It's important to note, too, that about 1/3 of patients who have HPS do not survive. Case fatality rates have been documented between 35 and 38%. The diagnosis of hantavirus pulmonary syndrome, or HPS, can often be quite difficult, but there are some specific signs that we look for. There is a diagnostic triad that includes the following. Thrombocytopenia. This thrombocytopenia is often the earliest and most specific laboratory abnormality that is noticed and often occurs in isolation. Importantly as well, this thrombocytopenia can be rapidly advancing or developing. But it's also important to note that the thrombocytopenia does not distinguish those who will develop more severe forms of disease later on. Additionally, there is often a left shift on a differential, and that left shift specifically includes immunoblasts, which are often greater than 10% of the total lymphocyte count. Some poor prognostic indicators include a plasma lactate level above 4.0 millimoles per liter, as well as a low cardiac index less than 2.2 liters per minute per meter squared. Chest X-rays will often be nonspecific, but usually show pulmonary edema similar to what would be seen in traditional ARDS. Unfortunately, there is no FDA-approved diagnostic test for hantavirus pulmonary syndrome or hantavirus in general. Serologic testing that tests for the levels of IgM and IgG can be performed at certain commercial labs, state public health labs, and at the Centers for Disease Control, or CDC, in Atlanta, Georgia. RT-PCR and immunohistochemistry tests can be performed but are usually unnecessary. The previously mentioned serologic testing ideally should include testing from pre- and post-infections to look for a 4-fold titer rise using paired samples. For a virus to be confirmed and entered into the United States Public Health Service's national database, it does require virus-specific laboratory confirmation, which is performed at CDC. This testing, or testing at CDC for this virus in general, requires pre-approval from the Viral Special Pathogens branch. Turnaround time is approximately 14 days, but the VSPB is available for 24/7 consultation by calling the Centers for Disease Control's Emergency Operations Center hotline at 770-488-7100. The management of HPS includes the following specific domains and principles. The first, anyone who is suspected of having HPS should be placed in droplet and contact precautions, if able, preferably in an airborne infection isolation room, or AIIR. These are negative pressure isolation rooms, which, if there is any concern for the Andes virus or person-to-person spread, will hopefully mitigate. The most important measure to take when managing these patients is through the use of good supportive critical care, otherwise known as optimized supportive critical care therapy, that includes fluid resuscitation, mechanical ventilatory support if needed, mechanical circulatory support if needed, and the management of potential co-infections. This has been shown to shorten the duration of the severe phases of the disease. Additionally, the use of extracorporeal membrane oxygenation, or ECMO, has been shown to dramatically improve survival in these patients. Patients who are usually meeting other criteria of ECMO and who have cardiac indices less than 2.5 liters per minute per meter squared are often considered candidates in these situations. Those who have been placed on ECMO have been shown to have an improved 50 to 80% survival rate. In terms of therapeutic medical countermeasures for HPS or hantaviruses, our targeted therapies are unfortunately quite limited. Ribavirin, which has been tried against a number of diseases for long periods of time, has been shown to be effective against hemorrhagic fever with renal syndrome that occurs in old world hantaviruses, though these studies that were done were largely small and underpowered studies. Ribavirin has been shown to have activity against Cynombre virus in vitro models as well as in deer mice models, but has not been tested in humans before. There have been small studies, again, using ribavirin and Andes virus, looking at in vitro and in vivo hamster models that suggest there may be a possible utility in post-exposure prophylaxis. Of most promising is that with monoclonal antibody therapy, using antibodies developed from that of survivors, and this is currently in development. Additionally, molecular checkpoint inhibitors are also in development against this disease, but have not yet entered phase testings. What we do know is that there is no role for glucocorticoids. An important study that looked at this looked at 60 patients in Chile with Andes virus HPS that were assigned to receive methylprednisolone at 16 milligrams per kilogram per day for 3 days versus a placebo. What they found was that there was no mortality difference between these two groups. The case fatality rate was both approximately 50%. In terms of preventative medical countermeasures for HPS, our armamentarium is even more limited. One of the reasons is that at the time of clinical presentation, which is often quite late in the disease course, the antibody response has been discovered to be very, very robust. Thus, there may not be a role for vaccinations for post-exposure prophylaxis or for pre-exposure prophylaxis. There are a few inactivated viral vaccines that do exist for old-world hantaviruses, but they remain very expensive, and currently there are no major plans by any large pharmaceutical companies to develop vaccines for hantavirus. The appropriate application of infection prevention and control practices does remain one of the most important tools that we have to combat this virus. With bunyaviruses, of which hantaviruses, both Old and New World, are a part, the distribution is worldwide. Thus, while travel history is certainly very important, exposure to the primary vectors, rodents and rodent feces, is crucial to identifying the appropriate patients. Thus, we must be sure we are asking the right questions to identify the right patients. Additionally, if there is any suspicion for exposure to Andes virus from South America, person-to-person spread might be possible. In terms of precautions, we want to ensure that we take at a minimum standard precautions with contact precautions potentially until this virus might be ruled out. Again, if there's a suspicion that Andes virus could be playing a role in the presentation of a patient, we want to be sure to also include respiratory protection by an N95 or higher mask, as well as eye protection with either a face shield or goggles. Additionally, we want to be sure that the source is controlled and that rodent droppings are certainly cleared up. Now, we've already discussed of the paucity of preventative medical countermeasures that exist, but there are some significant practical risk reduction measures we can take. This virus will likely not be prevented, and spillover events into humans will undoubtedly continue to occur, but here are some important measures to consider. In areas that are attractive to rodents, either for their food or their shelter, we want to be sure that ventilation is increased. We also want to ensure that we employ effective trapping methods for these creatures, and also that removal can safely occur. Additionally, portals of entry into homes, to other dwellings and other structures should be sealed off. The nests of rodents and other surfaces that appear to be contaminated should be cleaned, but prior to cleaning, appropriate measures with a disinfectant solution, often including bleach, should be performed. We want to make sure that also that we avoid sweeping, shaking, or brushing untreated surfaces, because these actions can certainly aerosolize the virus and pose larger problems and spread. While doing all of these things, we again want to make sure that we are wearing the appropriate personal protective equipment, which at a minimum should include standard and if possible contact precautions. When undertaking the cleaning and the treating of surfaces that might be contaminated, gloves, eye protection, and respiratory protection with an N95 mask or higher is recommended. That concludes the talk for today. I have provided some references for further discussion and investigation for those who are interested. And in the future, if any questions arise, please do not hesitate to reach out to either the MPR DHRS contact email that you can see on the screen, or feel free to reach out to me personally at my first name, gavin.lastnameharris@emory.edu. I again would like to thank you for your attention and hope you found this educational and enjoyable.